Thank you, Powell, for the introduction, and thank you, Kevin, for helping me set this up. So we will be talking about interstitial lung disease today, and it's a topic that was very arid for me when I was learning, but I think that they've organized it in a way that is more practical now. And I'm trying to be practical. So it's a whole range of different diseases, and they all have common clinical, common radiographic, and common pathological features. And some people think that they should be better called diffuse parenchymal lung disease because it doesn't only affect the interstitium, but it also affects the alveolar space too. So it's not interstitial lung disease, but diffuse parenchymal lung disease. But those two terms are interchangeable. So first, there's three broad areas that you should focus on. First is the clinical presentation. You have to find out if this is an interstitial lung disease or diffuse parenchymal lung disease that's related to a cause, because there's something that has a cause, and then there's unknown causes of interstitial lung disease.
It should be, yep. I think it's recording. I think it should be recording because I didn't exit out.
So there's different people involved with the patient in determining the cause, the diagnosis, the treatment. Pulmonologist, and then you'll have other people involved. You'll have the radiologist. You'll have the surgeons. You might have immunology also involved. So it's very important, the clinical presentation, to identify if this is an interstitial lung disease that's related to a process, a known process, because maybe you could identify something that, maybe it's interstitial lung disease secondary to medication, and you have to stop the medication, amiodarone. Or it could be a manifestation of a different systemic disease, like a collagen vascular disease that's treated with immune medication. Or it could be related to something that's reversible, or that could be treated. HIV. So it's very important to focus on the clinical presentation to see if you can get a clue as to if this interstitial lung disease is related to a disease or another process. So it's important to determine if the dyspnea is chronic, acute, the nature of the cough, the timing of the onset. It could be related to something. Age, gender, tobacco use, occupation, environmental exposures, family history, maybe it runs in the family, HIV risk factors, review of systems, rheumatologic review of systems is very important. And then on the physical examination, you should concentrate on, pulse oximetry to see if they are desaturating, inspiratory crackles, clubbing, extrapulmonary findings maybe could give you a clue. Complications, you ask for pneumothorax, hemorrhage. All those things may give you a clue and will tell you, your further step to go for other tests to see, or maybe that's enough to give you a clue or to give you a diagnosis. So as I say, the interstitial lung disease could be of known causes, or they could be idiopathic. There's some associated with granulomas, And then there's these rare interstitial lung disease that we always want to, the zebras. Known causes: environmental, pneumoconiosis, hypersensitivity pneumonitis, gases, fumes, iatrogenic, drugs, radiation. Maybe it could be related to infectious process, or it could be related to connective tissue disorders, or it could be idiopathic. And the idiopathic group of interstitial lung disease have been divided into 8 different types according to their pathologic description. And they also have common radiologic findings on the high-resolution CAT scan. So one of the most common ones, and that you're going to be asked a lot, is about idiopathic pulmonary fibrosis, which is a diagnosis of exclusion. But it has a very common clinical presentation, very common features, and very common findings on the X-ray. If those features are there, if it's very, you may not need a lung biopsy. You may just diagnose it with a history and findings on the high-resolution CAT scan. Then you have so usually if you do a biopsy, because you're not really clear if it's idiopathic pulmonary fibrosis, it will give you this specific pattern. It's called usual interstitial pneumonia. So then we have the nonspecific interstitial pneumonias, the pattern on pathology that has a better prognosis. And that pattern is usually related to collagen vascular diseases. It could be idiopathic, but very often collagen vascular diseases. Then you have acute interstitial pneumonias. Those present as if they were ARDS. They used to be called Hammond-Rich. Then you have cryptogenic organizing pneumonia, or they used to be called bronchiolitis organizing pneumonia. It presents kind of like a repetitive pneumonia with fevers. It has a good prognosis most of the times. Then you have the diseases that are interstitial lung diseases, but they're related to smoking. So it's very important to ask if the patient smokes. And sometimes, smoking cessation is a key. They could progress to fibrosis even if you stop smoking, but they're the respiratory bronchiolitis interstitial lung disease, and then there's the other form, desquamative interstitial pneumonia. They have very similar features, but the respiratory bronchiolitis interstitial lung disease is a little bit more benign. Then you have interstitial lung diseases that present with granulomas. And the most common one is, or one of the common ones is sarcoidosis. Now we have a lot of patients with sarcoidosis. Then we have Langerhans cells histiocytosis, Wegener's. It's not called Wegener's anymore. Or Churg-Strauss. They like to call it polyangiitis, granulomatosis with polyangiitis, and if it's Churg-Strauss, it's eosinophilic granulomatosis with polyangiitis. Those are vasculitis. They present with granulomas. And then there's these other rare diseases. But we are going to be focusing on maybe the common ones, and then the patterns on the idiopathic interstitial pneumonias. So first you got your history, and then you see if you can find out if it's related to a known cause. So then maybe you're still stumped about what is causing the interstitial lung disease. So you have diagnostic testing, or maybe you want to confirm. You've got PFTs, that could be helpful. Most of the times you think that you may only see a restrictive pattern, but a few cases of diffuse parenchymal lung disease or interstitial lung disease also present with both a restrictive and an obstructive pattern, and that may give you a clue. Then you have the high-resolution chest CAT scan. You have bronchoscopy. Bronchoscopy usually is mainly done for a few diseases. It could exclude sarcoidosis or cancer or an infection. Yeah, it could diagnose eosinophilic pneumonia because you see eosinophils in the BAL, or pulmonary hemorrhage. But most of the times you need a bigger tissue, you need a lung biopsy, and you don't need lung biopsies just one little sector. You probably need like 3 different areas to be able to diagnose the lung disease. They usually go to a pathologist who's a specialist in lung pathology. Of course, before doing the lung biopsy and all that, you're still trying to investigating to see if the patient may have a collagen vascular disease. You request for HIV, and you also work up for vasculitis with Pianka and Cianca, rheumatoid factor. So say you go and send the patient for the PFTs. Some of the interstitial lung disease that have both of obstructive and restrictive component will be sarcoidosis, hypersensitivity pneumonitis, Langerhans cell granulomatosis, lymphangioliomyomatosis. A lot of times it's associated with tuberous sclerosis. And then it could be a combination of maybe somebody has an interstitial lung disease and they also have COPD. Well, I have some relative contraindications for lung biopsy. Now, somebody has severe honeycombing, you don't send them for lung biopsy. And then if they have severe pulmonary dysfunction, you don't send them for lung biopsy. Maybe somebody that comes in with acute interstitial pneumonia, ARDS type picture, you're saying like, what is it, secondary to? Do they have an infection? You're like, if those patients get intubated, the prognosis is very poor. And maybe when you're doing the test is enough to tip them over. So before they used to emphasize, acute interstitial pneumonia, rule out infection as a cause. Now they go like, you should be careful and evaluate the risks and benefits. And then say if they have a lot of comorbid diseases and they can't undergo surgery, then you don't want to do a lung biopsy in these patients. So common causes of diffuse parenchymal lung disease: sarcoidosis, hypersensitivity pneumonitis, the idiopathic pulmonary fibrosis that has a usual interstitial pneumonia pattern, a pneumoconiosis that you could probably get from the history, the vasculitis, and the cryptogenic organizing pneumonia. Those are common causes. So sarcoidosis. It's a disease characterized by the presence of granulomatous tissue. It's a systemic disease, so you probably have clues. You may have skin disease, erythema nodosum, adenopathy, uveitis. They always present with elevated LFTs. And then on pathology, you see a non-caseating granuloma. Histiocytes, which is just another word for macrophages in the tissue, giant cells, and lymphocytes. And in advanced lung disease, you can see fibrotic changes, and at this stage, you may not be able to differentiate it from other interstitial lung diseases that cause fibrosis. So we still don't know the etiology, and there's usually 4 stages that are described. Most of the time it regresses and it's benign, like in 85% of the cases. Stage 1, it has no obvious intrathoracic involvement from the pulmonary perspective. Maybe they have, skin sarcoidosis or whatnot. Then stage 1 is bilateral hilar adenopathy, and it's accompanied by arthritis, uveitis, erythema nodosum. Sometimes they come in with fever. It's the Lofgren syndrome. It has a very benign course, good prognosis. Then you've got stage 2, which has a pulmonary parenchyma is also involved. They have mild changes in the upper zone. And stage 3, you have pulmonary infiltrates and fibrosis, but without adenopathy. And stage 4, I don't think it came out, but the stage 4 is burnt sarcoid with honeycombing. I think it got cut off. Then you see the also non-caseated granulomas in sarcoidosis too. See, and then you see the giant cells there, and then you see the granuloma. Oh, I've got this. Wait, hold on. Make sure that I'm not pointing it towards somebody. The giant cell, then you see the granuloma here. Granuloma here. If it had debris in the middle, it would be caseating or necrotizing. So this is bilateral hilar adenopathy. They like to call them potato nodes. And I get the potato nodes. And then you've got reticular nodes, reticular infiltrates, and maybe there's a little tiny node there, like small nodes. And the high-resolution CAT scan shows subpleural nodes, which is one of the classical features. Here, they like to accumulate here. And then you see by the fissure, you see these little nodes here. That's classical. And it has a distribution that is perilymphatic. It outlines, see, this is a secondary pulmonary nodule here. It outlines a secondary pulmonary nodule. So we discuss a PFT. It could have an obstructive and both an obstructive and restrictive impairment. But in stages 2 and 3, you'll see restriction, and you'll see decrease in DLCO. And the treatment and prognosis, most of them resolve spontaneously, stage 1 and 2. You observe them, and if there's dyspnea or a change in clinical status, you order PFTs. And if you think that the DLCO is declining, the FEV1 is declining by 10%, you may start steroids. Or if other organs are involved, like the eyes, they may treat them with steroids. But if there's a decline in PFT, significant decline, you start with 0.5 to 1 milligrams per kilogram initially, and then you continue for about 3 months or so, 12 months. And then you evaluate the PFTs and you see if there's a response. If there's no response, you continue with the same dose. And if there's still no response, you might add methotrexate. Usually burnt out sarcoid is not treated. You have to continue it for 6 months at least to a year, and then lower it gradually to the lowest dose tolerated. That will suppress symptoms. They probably need also treatment for osteoporosis and whatnot. Then we have hypersensitivity pneumonitis, which presents differently. It's also known as extrinsic allergic alveolitis. It's a reaction in the lung that occurs in response to an inhaled organic dust. Sometimes the patient doesn't give you a good history, or they're not even really aware of it. An example is a farmer's lungs. Well, there could have people that have hypersensitivity pneumonitis and have a presentation of farmer's lung because they sleep on, feathered pillows. So they're allergic to it, and you're like, oh, no, I'm not in contact with birds. The exposure may be occupational or environmental, and the disease occurs, it's a type 3 or type 4 hypersensitivity reaction, so that means you're going to have some type of granuloma. The farmer's lung is due to thermophilic actinomyces in the moldy hay, and you're allergic to that. And bird fancier's disease is caused by the avian antigen. Like if it at work, what they do is they try to irradiate the mold, or they try to contain it so that it doesn't get infected by the actinomyces. So you could have, you could do something to prevent it. So the pathology it involves infiltration of the alveolar walls with lymphocytes, plasma cells, and histiocytes, another word for macrophages. So you have granulomas, loosely formed granulomas. And fibrotic changes occur in advanced diseases, and it may look in this stage, it may look like idiopathic pulmonary fibrosis. Like when it's very advanced, you might not be able to distinguish it. So the giant cells and the granulomas. So we've got sarcoid, then we've got hypersensitivity pneumonitis causing granulomas. Foreign body too, but that's not. You never know. Chronic aspiration could cause also like an interstitial pneumonia type pattern in the basis, and then you do a biopsy and you kind of like stain it and you'll see food particles or foreign body. Or VIX, I don't know. So the clinical features, it could occur in two ways, acute or chronic. And acute usually causes a fever, dyspnea, malaise, cough. It appears 4 to 6 hours after the exposure. A lot during works. It could be an environmental disease, a Monday morning fever. These symptoms occur for 24, 48 hours. Fine crackles throughout the lungs. They present with progressive dyspnea over a period of years, so you want to catch it early. And the chest X-ray may be normal, but may show a reticular nodular infiltrate. So it could be acute, and that's acute. What do you see here? Ground glass. So it's an acute inflammatory process. You don't see fibrosis, ground glass. That milky, hazy type look to the X-ray, to the CAT scan. And the chronic one, patients progress with dyspnea, and you have inspiratory crackles, Velcro crackles, because there's fibrosis. It shows a reticular nodular infiltration and fibrosis. It's predominant in the upper lobes as opposed to the idiopathic pulmonary fibrosis that's in the lower lobes. So there's different patterns that could give you a clue. But if it's advanced, you may not be able to distinguish it. And the pulmonary function test gives you a restrictive pattern later on, but it's one of the ones that could also cause obstruction with restriction. And the gas exchange shows hypoxemia, and it worsens on exercise. And then you have the collagen vascular diseases, and then particularly with systemic sclerosis and lupus, rheumatoid arthritis, it could lead to fibrosis. The dyspnea is often severe, and if you're not really sure, if the history is not very suggestive, I mean, you may, this is not something that you could diagnose with a bronchoscopy. You need a lung biopsy. And the treatment is steroids or a cytotoxic therapy, like you treat for the underlying collagen vascular disease. And so when to suspect it, you have to do the review of systems. Muscular, skeletal pain, weakness, fatigue, joint pains and swelling, photosensitivity, Raynaud's phenomenon, pleuritis, dry eyes, dry mouth. So all those, you ask for all those when you're doing your H&P or interviewing the patient. Well, you could have family history. So sometimes the patients may have like a positive ANA, but not all the features. They don't have a diagnosis of collagen vascular disease, but they have a few features, and then they have this interstitial pattern, this interstitial lung disease, and you end up doing a lung biopsy, and the lung biopsy is supportive of a collagen vascular disease, like, but not full, but all the clinical presentation is not fully 100%. For example, you might have on the pathology a non-specific interstitial pneumonia, and then you've got features, and they may call it interstitial pneumonia with autoimmune features, so they have a name for it. They may develop full-blown collagen vascular disease later on, but it initially the manifestation was a interstitial lung disease. So you're just expecting maybe, you know. Okay, so then now the other common one is idiopathic pulmonary fibrosis. So it has a typical presentation. It's a middle-aged, usually male, 55, 65, progressive shortness of breath. Poor prognosis when he presents with the shortness of breath, probably like 3-year survival, depending of the stage. He presents with clubbing, Velcro rails. You have reticular basilar and subpleural opacities. Usually no ground glass. That's a feature that goes against idiopathic pulmonary fibrosis. You know, they have honeycombing and loss of volume, and they have traction bronchiectasis, and it's a subpleural disease. Here you see it, honeycombing, and at the bases of the lungs. The type 1, you'll see skip lesions. So some areas of the lung will be normal, and other areas will be fibrotic. And this is a slow progressing disease, and it seems to be like there's focal areas of fibrosis. There's loss of type 1 pneumocyte. The one that the pneumocyte 1 is the one that has to do with air exchange, oxygen exchange, and there's proliferation of alveolar type 2, the pneumocyte, the one that has to do with repair and production of surfactant. So it's probably an abnormal function of the alveolar type 2 pneumocyte. And you can see fibroblastic foci and proliferation of fibroblasts and myoblasts. So it's an abnormal repair. And since we've got 2 medications that have been FDA approved since 2014, OFID and nintedanib and pirfenidone, and they decrease the progression of this fibrosis. They're not indicated for end stage, but they decrease. They've noticed there have been positive clinical trials. It doesn't reverse it, but it decreases the progression. So now we're trying to focus on identifying these patients early on. Maybe they're a candidate for treatment. Then, so we have special features. This is one of our tools. You know, the radiologist is also, you know, involved in this high resolution CAT scan, chest X-ray, CAT scan. So to understand the different patterns, you have to understand the anatomy of the secondary pulmonary lobule. So the secondary pulmonary lobule here is the smallest unit. It's like the functional unit. It's surrounded by interstitium. And then here in the middle is terminal bronchial, the artery, and the lymphatics. And then it divides into the sinus with the alveolar sacs. And then around it, you see the interlobular septum with lymphatics, and then the vein. So say if you have a toxin that you're breathing in, you know, it will go through the bronchus, and it may cause an inflammation, like it may cause a centrilobular nodule, like in the hypersensitivity pneumonitis. If sarcoid usually compromises around the lymphatics. You know, so you'll see nodules that are perilymphatic. So let's see, different. So you get nodules, and you could have, they could be reticular, nodular, high density, low density. They could have a centrilobular distribution or a perilymphatic, like this perilymphatic, or centrilobular here. See, this is like the outline of the secondary pulmonary nodule. It's not visible usually, but they, kind of like it's there. And then random distribution. See, these give you a clue to maybe what diseases it could be. This is centrilobular ground glass density. This is tree and bud, which is usually means an infection maybe, or bronchial, that it's coming from, it has a bronchial component to it. So if it's a nodular pattern, you could have multiple nodules. You could have pleural-based nodules, no pleural-based nodules. So the diseases that have pleural nodules, it could be subpleural, septal, peribronchial, perilymphatic, sarcoid, silicosis, and lymphangitic spread of cancer. Say if it's diffuse, random, that's miliary that's usually infections or metastasis. If it's not pleural base, if it's centrilobular, see, hypersensitivity pneumonitis, respiratory bronchiolitis, maybe bronchoalveolar carcinoma, or other infectious diseases. So if you look at the pattern, it will give you a clue. So you have the clinical picture, then you have the x-ray picture, and then you've got your laboratory tests, the PFTs, and if you put that all together, it may point towards a disease. It's kind of like an algorithm here. So sarcoid, just by looking, so it's septal thickening. You could have septal thickening. Sarcoid is always nodular and irregular. If it's smooth, it's something else like CHF, for example, or something else more benign. But nodular is sarcoid or lymphangitic spread of cancer. See, this is a nodular septal thickening. Nodular. And it's around the, it's not centrilobular, it's around the lymphatics, perilymphatic nodule. Sarcoid, lymphangitic spread of cancer, silicosis, lymphocytic interstitial pneumonia, and amyloidosis give you that pattern. This is centrilobular. See, it's like in the middle. I must kind of like, if you imagine it, you can see the secondary pulmonary nodule. It's not supposed to be visible, but you see these loosely formed nodules. That's classic of hypersensitivity pneumonitis. You could see it in respiratory bronchiolitis in smokers. You could see it in infectious airway diseases, but give you another pattern. It's called tree and bud. You could see it in bronchoalveolar carcinoma, but it's rare. And in pulmonary edema and vasculitis. So this is another pattern that you could see on the high resolution CAT scan is ground glass. It's an attenuation. It's like a density. It looks like this milky kind of background. And it means acute inflammation. It can mean an infection. Acute. You can see it in acute eosinophilic pneumonia. It could have a chronic pattern to it if there's fibrosis. If you see fibrosis, see there's fibrosis here, and maybe there's a bit of ground glass. You could see that combination in chronic hypersensitivity pneumonitis. An organizing pneumonia could be chronic, but it doesn't give fibrosis. Then you have chronic eosinophilic pneumonia, and then you could have nonspecific interstitial pneumonia or idiopathic pulmonary fibrosis or cancer too. And then honeycombing right here, and usually subpleural, and this is a traction bronchiectasis almost, and this is probably usual interstitial idiopathic pulmonary fibrosis. So this honeycombing pattern could be idiopathic pulmonary fibrosis or advanced stages of a collagen vascular disease or end stage of hypersensitivity pneumonitis or end stage of sarcoidosis. You see this. There's not a lot of ground glass. There's this honeycomb. There's nothing much that you could do. No steroids on this patient. So then you have your clinical person, the pulmonary doctor. You have your radiologist, and then you have the pathologist. If you decide to do a lung biopsy, are we okay? So there's these 8 types of pathologic presentations, and they each go along with some diseases. They're interchangeable. This one, usual interstitial pneumonia, you could see this pattern in burnt out hypersensitivity pneumonitis. And this one is very often in collagen vascular disease, or sometimes it's idiopathic. This one is unknown why, but it has a good prognosis. This is related to smoking as well as this. You see the hemosiderin Latin macrophage. Then this one looks like ERDS. And lymphoid interstitial pneumonia is rare. You can see it with HIV, idiopathic. And then this is a new one that is very rare. So those 8 patterns, 2 of them related to smoking. These 2 related to fibrosis, and this one with a benign progression. So we already spoke about that. Is idiopathic pulmonary fibrosis. Poor prognosis. This is what the biopsy looks. See, this is almost normal lung, and this is an area of fibrosis with collagen deposition. You could almost see like areas like of normal lung with abnormal lung. So it has the skip lesions. The nonspecific interstitial pneumonias, very often associated with an autoimmune disease, some of them idiopathic. It has a better prognosis. Few of them progress to fibrosis. You see a lot of ground glass, and it's upper lobe predominant and pleural space sparing. So it looks kind of like that. That's fibrotic nonspecific interstitial pneumonia, which has a worse prognosis, and that's cellular. And then you've got the cryptogenic organizing pneumonia that presents almost like a pneumonia that repeats itself, and it's migratory. Minimal fibrosis or long-term sequela. A desquamative interstitial pneumonia related to smoking, so smoking cessation is very important. And respiratory bronchiolitis interstitial lung disease is kind of like has a shared spectrum. On the CAT scan, it's central diffuse ground glass infiltrates, minimal fibrosis. I wanted to go through the.
Let's see.
Through the questions.
Questions?
No, but let me just go. Let's go through the questions. The fun part of this is to get a history and put everything together and come up with a diagnosis, which probably in the future a computer will do. I mean, you just feed the findings, and then it probably would spit, oh, this is sarcoid.
Mm-hmm. You can use the mic and I'll just.
What?
All right.
But you still have to feed the findings and the workup.
All right. So we're gonna go over a number of questions. So we'll start with question 60. Okay. All right. So who volunteers? Andrew?
70-year-old man is evaluated and followed up for COPD, which was diagnosed a year ago. He was in 2 exacerbations in the last year. Second exacerbation 1 month ago. He's also had a baseline chronic cough and mucoid sputum
I don't think this is the question.
for the last 3 years. Sputum
I
culture
don't think this
6
is the
months
question.
ago through Haemophilus
I think this is the
influenza
question.
and MAI.
I think
He
that
has,
this
he has to
is
stop and catch his breath
it
after
was a
walking
different
100
Oh.
quiz
meters.
bank.
His inhaler
It's
technique
okay,
is
we can
good.
answer this
Quit
question.
smoking 2 years ago and has completed pulmonary rehab program 4 months ago. His medications are tiotropium, fluticasone, salmeterol, and as needed albuterol. Spirometry performed 3 months ago shows an FEV1 of 32% of
Obstructive lung
predicted
disease.
and FEV1
It's a different
over
question.
FVC ratio of 50%. Chest radiograph performed last month shows no infiltrate mass or increased congestion. On physical exam, vital signs are normal. O2 sat is 92 on room air. Pulmonary exam reveals diminished breath sounds. Which of the following is the most appropriate long-term treatment?
No.
We'll go to another one.
No, we.
So
So
it's
I think I know the
looks
answer
like
to this
it's
one.
advanced COPD, still having exacerbations despite his current treatment. So maybe for him, abroflumilast.
Rofumilast. Why not daily azithromycin?
I don't think you do daily azithromycin, do you?
Fair enough.
No, it was just for exacerbations.
Okay. What about prednisone?
Daily
Probably not, right? It's not asthma, right? Simvastatin? No?
Not really at all.
Okay. Alright. Perfect. Alright, guys. So let's see. 44. 44. Is this still on? Yep. Okay. So, Sharif. So this is the question they're asking, right?
Oh, no, those are the answers.
So the answer, sorry. Right. So we'll go over the stem. You forgot the question? Yep.
So he has
There's a lot going
he
on,
has
right?
a diagnosis of idiopathic pulmonary fibrosis. He's 75 years old, and he has a progressive decline. He's on oxygen. He also was treated for also already completed a dose of steroids.
Mm-hmm.
No? He
Yeah.
already had an acute steroid, and other things have been ruled out.
Right.
And then he has signs of JVD and a loud S2, like pulmonary hypertension, cor pulmonale. So he's old, and he has a high CO2 now, like at baseline, and he's hypoxic. And the CAT scan showed
Ground
fibrosis
glass.
and no ground glass, or minimal ground glass, like end stage. So more steroids, hospice care. Would you intubate? Or would you does he have any contraindication for lung transplantation? Would he be a good candidate? Does he have the appropriate age or any risk factors? Would he die on mechanical ventilation if you transplant him? Would he have high? Would he be a high risk to end up on ventilator after the lung? What do you think? What would you pick? Like this?
So he's elderly. He has multiple comorbidities. So probably no lung transplant. Right. So he's not doing well.
Right.
Probably hospice.
Hospice? Final answer? All right. Good job. Do we have more time? I think they were done, right?
Yeah.
Should be done. Okay.
Okay.
Thanks, guys. Thanks, Doc. Thank you again.
You're welcome. Was it okay?
Yep, that's good. Thanks, Doc. No. Sharing the thing. Leave me. Okay, so let me go down.
Okay.
Finish up. Just try to.
Next year, maybe. Are we working on it?
Kevin. Yeah, I don't know what. What about the water? Wait, yeah, you guys can go, then you should go. Yeah, so far I haven't had any issues.
Oh, yeah.
I'll show you.
There's another restaurant that is
Just hold on, because I'm trying to see this thing. All you have to do is go there.
works.
Yeah, so maybe you can show him.